podcast.
Mas o dólar, a moeda aí, ele entendeu.
Não entendeu, não.
Aí quebra o
Você
cabo,
fala
né, velho?
rápido.
Quebra o cabo, né?
Não. Vou mandar então mensagem para você, que eu não entendi, não. Vai lá. Vou mandar aqui.
Não, é tipo um sponsorship.
Sim.
Mas às vezes é melhor você alugar. É porque o network que ele tem é muito grande também, né? O networking que ele tem, né? A rede dele é grande. Né? Já tem 14 participantes, tá vendo? Isso dá umas 400 visualizações, bicho, depois 500. Onde eu chego, o povo reconhece a pessoa, tu acredita? Cara do Caribe, já conhecia. É. Não sei se isso tem algum valor, mas...
We're ready in 2 minutes, okay?
Ok.
Well, I want to just say one thing, that it is lucky that this disease is at L1 level predominantly.
Can you transform Dr. Evans
I want to know that S1 or S2 level, we would have to sacrifice L1 levels in bladder easier level to operate. So if this was a relatively easier place to operate, we would have to
John, can you stop the other transmission?
Should we go to the third case, Sangeet? Yeah, I think so. Relatively easier place to operate. So you can stop sharing. Should we go to the third case, Sangeet? Yeah, I think so. So you can stop sharing. Mirza, you can suggest the third case.
John, can you stop the other transmission? Is
Hold on.
disturbing our broadcasting.
Okay, what is it? You're getting background noise?
Okay. Dr. Evans, can you transform him as a panelist? Can you move him to...
You can do it.
I have problem here.
You can't do it? Okay.
Stiffness,
You got it? Who do you want to let in?
Evans.
Don't have even.
Occasional urinary urgency, no relief with over-the-counter medication. She has an MRI of cervical spine with VOC with extensive core T2 signal, differential diagnosis edema or myelopathy from C3 to C5 levels.
I don't see even. Do you see?
Even.
C4-5.
Evan? No.
Oh, he's here. I'm here. I'm ready.
Because you were with my name, Evans.
Spasticity, inability to walk, weight gain of 20 kilos over 2 months.
You have to transform here.
And following the surgery, she has an Ashford grade 3 spasticity.
Do you see the picture? Do you see my
extensor?
Yes, the slide. Yeah.
My slide? Yeah.
Yeah.
Significantly poor grip of both hands.
Could you get off your screen share so we can introduce you before you speak?
Good morning, John.
Good morning. Welcome, everybody. Atul is two-timing us on another channel. So he'll be here in a while, and we'll let Marcos arrange what's ever going to happen. Anybody else to be admitted, Marcos?
Hi. Evans, are you okay?
Okay, I'm okay. I can start out.
Oh, okay.
I need my audífonos.
Okay. Hope you don't mind. I'm going to take you off the screen there so we can introduce your face.
Was the first surgery appropriate? How long should the waiting period after first surgery be before deciding a repeat intervention? What is the plan of management now? So I will just quickly show the images. This is the index MRI.
And they run inside.
Would you like to comment to this?
Wow.
Okay, here we go. You ready to start, Marcos?
Yes.
Okay, here we go. Okay, hold on. Okay, here we go. 10, 9, 8, 7, 6, 5, 4. Oh, wait a minute. I haven't even put it on record yet. 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach. Today we have another Brazilian webcast designed, actually it's the fourth webcast of the tool. Fourth, right, Marcos? I think it's the fourth.
Hi. Hi, everyone. Here is Marcos Wagner from Brazil, and we're now, unfortunately, ending this 4-chapter series with Professor Atul Goel. And welcome, everyone. Here we're going to discuss a little bit about school-based high surgeries. But before, I want to invite Dr. Luis, which is the president of our society, to welcome everyone. And then Dr. Ivan's lecture related to Chiari malformations. Welcome, everyone.
So that is my first question.
Luis?
What would I do? Welcome, everyone.
John, the audio from other is disturbing us.
There's a conflict of audio.
A conflict.
I don't think if the patient goes in after surgery. Okay.
Oh, we have someone else.
Luis?
Is it okay? Are you hearing me?
Yes.
Yes.
Okay. On behalf of our society, it's a pleasure to have here some specialists like Professor Evans, Professor Fabio, and Professor Atul Goel to discuss on these skull-based topics. And it's the fourth event on this series. And after this, we will continue doing this kind of events that are very rich for us neurosurgeons here in Brazil. So please, let's start for the first lecture.
First of all, I thank you all for the invitation, Professor Goel and Professor Bennett. I'm going to discuss here a very different topic because it's more an anthropological topic than neurosurgery as well. This is a work that I've done 10 years ago. Why people have Chiari malformation? Because we don't have a good answer to explain it. And I did some research about this topic. And I came with this hypothesis. I'm going to show you briefly. Sometimes you have to think out of our mind. You have to open our drawers and try to find the reasons why some disease appears.
I kind of like that. They are quiet.
Sorry?
Continue.
Okay. Anyway, I wrote this paper about 10 years ago that trying to explain why people have Chiari, because when you read the books, when you read the papers, you just learn that Chiari malformation is tonsillar herniation of about 5 millimeters below the foramen magnum. But this is a radiological definition. It's not the definition of the disease per se. So we may be confounded by that. We have a radiological definition, but we don't have the cause of it. So you must separate things. This is always bother me. Why the definition is only radiological, not the cause of the disease. So the Chiari is an intriguing disease because unlike many other diseases that have common, quite understandable pathophysiological rules, Chiari one seems to follow a rule of its own. We know that Chiari may affect this kind of dogs, Cavalier, King Charles Spaniel, and we know that it was caused by interbreeding. And we know that Chiari have a small posterior fossa, and in this kind of dogs, you might have 50% of syringomyelia. So because of that, I thought that is it Chiari and interbreeding in humans? We know that everything starts out in the posterior fossa. We know that Chiari is related to the posterior fossa, to the cleavage somehow. Okay, and you know that the average of the cleavage in human being is about that in the book of Lang, 45 millimeters. And you know that people with Chiari malformation, most of them have a small clivage. Okay. So why people with Chiari malformation have clivage hypoplasia? Is it a premature stenosis? Is it undevelopment of occipital sommity, paracardoplatia? Can we find a simpler explanation for it. Anyway, we know that normally people, the posterior fossa occupies about 56% of the posterior fossa, and the supratentorial space about 73%. And we know that when we have a shortness of the clivus, we lose some space, about 5% of the space is lost in the posterior fossa. So this may cause the herniation of the tonsils because of this shortness. And when you compare the group of this work of Miller et al., we know the posterior fossa volume in the Chiari group is less than the control group. So the Chiari malformation is like a funnel-shaped posterior fossa. When you have a Chiari malformation, as the posterior fossa is shorter, we have a turbulence of the flowing of the LCR, but in a normal case, we don't have this problem. So this might create the syringomyelia because of the turbulent effect of the LCR. So because of that, I start to think about if you don't have...
Excuse me, everyone is looking for his slides.
You don't see
Nope.
it?
Nope.
No.
Nobody see it?
You have to share the screen, Evans.
I did it.
Is it okay, John,
Wow.
to see the lecture?
No, could you please share it again, please?
I did share it. It's not working out?
No.
Oh, sorry.
It fell off.
I thought I had shared it. Just a moment. Nobody saw it.
No.
Not yet.
Ana Clara?
There is share screen, and you have to... Tem negocinho aí de...
That's right.
Okay, pronto. That's okay. Can you begin again, Evans, please? Restart. No problem, we have time.
Yeah, I'm sorry. That's my fault. I'm sorry. Okay, you're muted. You're muted, event. You're muted.
Clica em reproduzir.
You're muted.
Tu tá mudo, Evans. Libera teu som aí.
Yeah, I need to get some help on these
Okay.
webcasts.
Okay, Evans, pronto. Okay.
Do you see it?
Yes.
It's
Oh,
not.
really?
It's not presentation mode. It's
Oh.
gonna get the screen's gonna get
Coloca
bigger.
modo de apresentação.
Aonde isso, hein? Presentation mode on.
Se você clicar aqui,
Clica reproduzir nesse playzinho ali que tem em cima, mais à esquerda.
aqui, ó, reproduzir. Reproduzir. Aí.
Apareceu?
Reproduzir.
Tá, só um pouquinho. Apareceu?
Não, a sua tela tá ok. Agora só falta ver, assim...
Não apareceu, não?
Reproduzir.
Yes,
Pronto,
okay.
agora.
Okay, perfect.
Is it okay?
Perfect.
Okay.
Okay. Okay, sorry for the problem.
No problem.
Well, let's start over again. This is a very different topic. It's about an idea that I had about 10 years ago about Chiari 1.
Por afuera anda.
Sorry? Don't see it?
Vai.
We can see it. That's fine.
Maria,
Okay.
ven. Toma el teléfono.
But I cannot change the slides.
Can't go to the next one.
I'm not sure.
Okay.
A setinha para a direita. A setinha.
Não estou achando, cara.
Clica em cima do slide.
Clica na tela.
Okay. Second slide, okay?
Yes.
Okay.
Good.
Well, sorry. Sometimes you have to open our drawers of our mind and try to find out the reasons why disease appears, okay? So I wrote this paper about 10 years ago to try to explain why people have KR1 malformation, because most of the time, when you read the books or the papers, they tell us that KR1 malformation is a tonsillar herniation, a 5 millimeters herniation of the tonsils. But this is not the cause of the disease. This is just a radiological finding, okay? And because of that, I tried to find a reason why we have patients with KR malformation, because this is an intriguing disease. Unlike many other diseases, they have a common, quite understandable pathophysiological rule. KR1 malformation seems to have a rule of its own. And we know that KR disease also affects this type of dog, the Cavalier King Charles Spaniel. And this kind of dog have a small posterior fossa, and they have syringomyelia in 50% of the cases. And we know that this kind of dog had this problem because of interbreeding. And we know that the problem is around the clivus, and the clivus has about 45 millimeters in human beings. And we know that most of patients with KR malformation have a smaller clivus. So why people with KR malformation have clivus hypoplasia? Is it a premature stenosis of the sphenooccipital synchondrosis? Is it an underdevelopment of occipital somite? Can you find a simple explanation why people have a smaller clivus? We know that the supratentorial and infratentorial space, if we divide it, the posterior fossa has about 56% of the volume of the cranium. In KR malformation, this volume is about 5% less. It's about 20%. That's why they have the tonsillar herniation, because the posterior fossa is smaller. When you compare this group of the posterior fossa volume in patients with KR and patients in the control group, we see much less space in the posterior fossa in KR patients. Sorry. And so, if you think that the posterior fossa is a funnel-shaped thing, in KR malformation, you have these turbulent waters flowing because of the smaller fossa, and in normal persons, we don't have this kind of problem, okay? So that's these turbulent waters that cause syringomyelia. So I start to think about if you could go back in time and try to link Chiari with paleoanthropology, maybe you can find the reason why Chiari-1 exists. So I start to study the human origins, head evolution, brain evolution, clavar evolution, and skull-base evolution. I did some work on it. I studied about 5 years, during 5 years, to try to understand why we have Chiari malformation. And paleoanthropology has evolved a lot. It evolved from a descriptive and historical discipline to an analytical, genetic, and biomolecular one. So we have a lot of information, much more information about our evolution nowadays than in the past. And you know that from this, the origin of the hominid species was linked to bipedalism and brain growth. And you know as well that humans, chimps, and gorillas had a common ancestor. And we even know that almost 90% of all primate species are unknown, and only 3% can be found as fossils. As well, we know that the Africa is the cradle of humankind, and during this development and evolving of our species, occur a lot of interbreeding. We know nowadays that this interbreeding was doing to all these models, replacement model, assimilation model, or gene flow model. And during this interbreeding, new species were formed. On this very interesting trellis model development of Templeton, we know that Homo erectus, Heidelbergensis, Neanderthalis, and Homo sapiens, somehow they lived together during a period of time, and they interbreeded with each other. And during this evolution, the brain, that's the nature's masterpiece and the most expensive body machine, had grown a lot. For instance, the brain is five times larger than predicted by our sizes as human beings. So during about 5 million years, the brain has grown this 4 or 5 times its size. And because the brain had grown, the skull and the cavara had to grow as well. And the cause that made the brain grow is linked to fire control, cooking, harsh environment, competition, and handmade. This is the theory that the hand made the brain, and the brain made the hand. So all these facts together made our brain grow. And because the brain had to grow, they had to have 2 partners, cavara and the skull base. So the brain said, cavara, let's grow. And the brain said, okay, let's grow. Single mission. And the cavara has grown in 3 slight different directions. In this direction, dolichocephaly, mesocephaly, and brachycephaly. That's the way cavara helped the brain to grow. And perhaps this explains as well craniosynostosis, because of this development of the brain and the cavara. So if you see in this slide, the cavara evolution, we had these positive signs, was done like that. But interesting, we have negative signs here, okay? So this is interesting because the cavara has grown, but this region has changed its shape. I'm going to show you later. So to the cavara was a simple mission, but to the skull base, when the brain said, let's grow and walk, because we had to, beside grow, had to walk, to the skull base, this mission was more difficult, was a double mission. And this double mission had to be done in a different way, okay? So the skull base, instead of growing, it had an evolution that I would call revolution here, because the skull base had shrinked. It has shortened its size to fit this new model. Okay, so if you think about bone, we have what we call isometry and allometry. The bone is the best material to be molded. So if you have a femur, you want to grow, it will grow. This is isometric growing. But if you have, in this case of the skull base, instead of growing, it was reshaped. It was bent. So the bones of the skull base had bent to accommodate the new size of the brain and to make human beings able to walk. So instead of having a brain box with the skull and a flat skull base, we had a brain sphere and a ramp, a private ramp to accommodate the skull and make it possible human beings to walk. So the skull-based revolution was this kind of Clive rotation during these 5 million years that made possible human beings to walk. And so we had isometric changes in the anterior fossa, isometric change in the middle fossa, but we had allometric change in the posterior fossa. again, we change from the brain box and big snout to a face and a brain sphere. Okay, all this happened during all this time. And what's interesting that the length of the skull base in the ancient hominids and even in the loris is longer than in human beings. So human beings have a short skull base. This is well proven. Okay, and even if you measure the length of the skull base and the endovolt base, you see how short is our skull base. Why the skull base length is so short? Because we had a problem of packing the brain. So the brain has changed it to a sphere because the sphere can accommodate the brain. And the posterior fossa had these changes, and this happened to make the foramen magnum advance to, again, make possible people walk on the feet. I'm not going to go into details, but these are the angles of the basal angles of the erectus, heidelbergensis, and neodentalis sapiens. So the C shape has a smaller angle. Okay. And it's interesting because if you see a patient with platybasia, we know right away that platybasia has two meanings. Okay. The first meaning is that the basal angle, in this case, and the second meaning, that's platybasia, means that you are seeing a patient with an ancient skull base. So in this patient, the skull base has not developed. It's still an old skull base. Okay. So I guess in Chiari malformation, brain and the brain case, they have a desynchronization. The brain could not, the skull could not shelter the brain properly. So, in my opinion, Chiari malformation is a clash of species. Perhaps allopathic populations met each other and mingled. Perhaps people, we still have the archaic genes of ancient hominids. And this caused this mismatch between the skull and the Chiari. We did this work at the Universidade de Campinas, and we presented in New Orleans 10 years ago about platybasia and Chiari malformation. And in this work, we tried to measure the basal angle in patients with Chiari malformation and patients without Chiari malformations. And we found something interesting, that in Chiari group, the angle was bigger than in normal group. And if you see this data, in Chiari group, we had the mean basal angle of 122, and in control group 112. And if you see that in Chiari group and control group, the angle is slightly different. And obviously, in the Chiari group, if the angle is has this difference, we have a small space to the posterior fossa. So to end this presentation, I guess you'll have a take-home message. If you want to understand Chiari, you have to understand 4 key steps. The first step is that our body is unfinished. So it's a French concept, the corps inachevé, unfinished body. Our body is still evolving. The second, if you apply anthropology to Chiari malformation, we may understand that you have it's a 3-piece puzzle. And finally, the clivus ramp. So we had the problem of the brain that had to grow, and the calvaria, and the skull base had to help it during this process. Okay. And you have these changes, this change of the positive and negative forces that made the skull base be shortened. And the last step is the clivus ramp. So along our evolution, the clivus had changed its size and its slope. The slope of the clivus has changed, and I guess chiasm malformations is linked to this clivus ramp that is shorter or has an angle that makes the posterior fossa less, that gives less space to the posterior fossa. That's it.
Very good, Dr. Evans. This is an anthropological view of the matter, of the topic. Professor Goel, are you there? Very good, Dr. Evans. It's a
Thank you.
beautiful philosophy of facing this disease.
Thank you.
All of us want to discover
Something.
what begins first.
Yeah.
This was indeed a very wonderful scientific, philosophical presentation, and I enjoyed it. I didn't hear it completely, but I'm sure that there are some wonderful points in what you were saying. And needless to say that it is important to understand this subject more so as so that our patients can be benefited and they can get the results of our treatment. I wish you all the best.
Thank you,
How'd
Dr. Goel.
how'd the king sneak in there without us acknowledging him?
Professor, the sequence today, we have two Brazilian colleagues that Evans wants to share his theory for the world, and now is Dr. Ronconi, who wants to speak about school-based access, endoscopy, his experience in a couple of minutes, and then you are free to give your talk today, okay? Is it doable?
Okay. Okay, fine.
It will be all fast for us not to take much time. So thank you, Evans.
Thank
And
you.
Luis, I were in the Congress of Spinal today in São Paulo, and we were discussing about the great amount of Chiari malformations here in Brazil, in our region specifically. And we can begin, Evans, with your help, Fabio, and everyone, even Professor Atul Goel, to begin a campaign here to clear people, to bring this knowledge for the regular people to know about Chiari malformations. Because here, Professor, we got lots of patients in adult age, you know. I think we must make a task force maybe to make more screening with this disease here in our region, in Northeast region of Brazil. Lots of patients, Professor, we have, and they just come us with atrophy in their hands, you know. I know that we must do a great, I don't know, it's a campaign or something like that here to make more known about the disease. Okay, André Ronconi, please, welcome. Daniel Ronconi is a neurosurgeon from Brazil, Northeast region of Brazil, and he has a great experience on endoscopy of the on a neuroendoscopy here on the Indonesia. And welcome, Daniel. Feel free to give your lecture.
Let me just find here.
Viu, Luiz? A gente pode fazer uma campanha de Chiari malformation no Nordeste, sabe? We can discuss afterward this.
Okay. Daniel having a hard time loading it. Where'd he go? Did he disappear?
Daniel? Roncone?
He must have fallen off.
Well, that's
Just
great.
wait this. There you go. There you go.
You
Are
can
you-
use your,
Yeah.
you're beginning a new, okay, okay, thank you.
All right.
Is it working?
Perfect.
Okay, thank you. Thank you, Dr. Marcus Wagner, for the invitation. So I'm going to talk a little bit about the use of the endoscope in the CP angle surgery. Okay, it's a short lesson, so then we can discuss some cases here. Thank you once again for the invitation. My name is Daniel Roncone. I'm from Brazil. I live here in João Pessoa, Paraíba. Okay, so we have to differentiate the use of the endoscope between the endoscope controlled surgery, is when we use the endoscope during the whole surgery. So we just have the endoscope as the way to see the surgery, or we can use the endoscope assisted image. So when we use the endoscope to assist the microscope surgery. This is the one that I prefer. I think it's better than the fully endoscope. Nowadays, people are doing a lot of MVD surgery, just full endoscope. But I have already done it, but I don't know if it's the best way to do. I'm going to show some cases, but so this is the way that I prefer, the endoscope assisted. And why we have to add the endoscope to the microscope on the surgery of the CP angle surgeries. So a lot of works in the literature has already proved that when we add the endoscope, we can extend the surgical field, especially from points that we can't see through the microscope. It then allows us to visualize and resection a lot of tumors, sometimes tumors that are hidden between the corners, and we can improve our prediction of extent of our resections. When we are talking about the endoscope inside the CP angle, when we are using it in our surgeries, we have some advantages, especially the panoramic view. When we are using our 0 degrees lens, we can have that fish view. So we can have a expanded view. We can look around corners. We can have a close-up view and a brighter illumination, especially for points that are deep located. A main disadvantage should be the bleeding, that especially that you can cause with your instrument when you're using the endoscope in the CP angle. The lens always has to be clean. It's almost like an endonasal surgery. So if you have to sometimes it's tough. You have to clean a lot the lens. You can deal with thermal injury. I think this is a theoretic risk because we really don't see it in practice. But if you leave your endoscope there, a lot of time you can have some problem. The learning curve should be a little bit steeper than the microsurgery isolated, and a poor operative field. So when we see this phrase, we can say, oh, but it's completely different from what I talk already. But we are talking about the field that is just behind you. When you use the endoscope, you just see what is in front of you. So we have to take a lot of care to not injury, especially nerves that are located behind your endoscope because you're not seeing. That's why sometimes we add the endoscope we are using the microscope. So we use both of them to watch and to operate. So here is a schema that we can see a lot of the advantage of using the endoscope. I don't know if you are seeing my pointer here. Are you seeing there? Or no? Yeah? Okay.
You can see it. You can see it.
You can see it? Okay. So here is the tumor, and this is how we use to work with the microscope. We have the hole or our axis, and the tumor is located behind or in front of some structures. And when we are using the microscope, we just can angulate it. When we add the endoscope, we can bypass these structures that are in front of the tumor, and we can see it straight, in a straight view. And when we are dealing with this special example, this is a high point, we can use the endoscope to watch it, especially, for example, a small piece of tumor that is below of the nerve or sometimes inside the acoustic channel. So we can see the tumor. So when we are working with the endoscope, I think we have three main ways to work it. We can use the holder, the same way that we can do in the nasal approach or some ventricular surgery. So when we're using our holder, we can reduce the reduction of the shake movements. We can reduction the movement of in and out inside the CP angle, and then we can minimize the trauma of the neurovasculature of the CP angle. The main problem of the holder is that we can't see the instruments that are going in and going out. So that problem that I said about the poor visualization of the field that's behind you, you have a lot of this with the holder. And we don't have that dynamic visualization. So the 3D visualization that we have with the microscope, when we use just the holder, we lose it. On other hand, when we use the freehand technique, we have a dynamic visualization, and then we can improve our stereoscopic view. And the endoscope, especially if we're working with a second surgeon, the endoscope can guide the instrument exchange. On other hand, we have to deal with the shake image because it's a human that is there holding the endoscope. We have the risk of the CP angle trauma because the endoscope will follow the instruments, and we have to have a lot of synchronicity between the surgeons. So should be someone that has the same experience that you and someone that works with you, so then we can work together. This is how we do most of the times. We work in two surgeons. One hold the endoscope, and the other one will work inside it. And we also has the one surgeon freehand. This is an adaptation that we do from this technique described by one of my mentors, Professor Fröhlich. Professor Fröhlich has described this chopstick technique that we use for endoscopic surgery, endonasal surgery, that the surgeon with your non-dominant hand, you can hold the endoscope, and you can also hold the suction, and it's a malleable suction that we can adapt the point. And with the other hand, you hold the main instrument. So like this, just one surgeon will work with the instruments. It's not an easy technique, but if you try this on your endoscope, on your endonasal approach, you can apply this to the CP angle surgery. So when we use this kind of technique, we improve our stereoscopic view. We don't have a lot of sword conflict because it's just one surgeon that is holding the instrument, so you don't cross the instruments inside the field. In my opinion, it's ideal for bloodless and soft lesions, but for dissection and sections, especially those lesions that are very attached to the nerves, is not for me is not a good option. And the learning curve is very steep. This is how we do for the endonasal approach. This is an adaptation. Here we have the endoscope, the suction tip, and like this is the drill here. So just one surgeon using the whole instrument, the three instruments. And this is a suction control that we use. Sometimes when we are doing this approach, this chopstick technique, the second surgery or even your instrumentist has to use this to control the power of your suction. It's very important because sometimes you can take a nerve, so you can diminish this, and then you can work safely. Here's the kind of lens that we can use when you're treating these pathologies. We can use the 0 degrees, the 30, or the 7, or the 45. In my opinion, I prefer use the 30 degrees lens. I think it's better because with just one type of lens, we can have different views. So like this, we can see here, just turning around the endoscope, we can have different views. So we can look toward the brainstem, or we can look toward the cistern, we can look toward the clivus, toward the nerves. So like this, we have better visualization. The position that we can put our patient is the same that we do for microsurgery, park bench. We used to do a lot of park bench position, but nowadays most of the cases we are doing like this, a dorsal decúbito with just a head rotation. And sometimes we are trying also the semi-sitting position. The incision we can do when we are planning to do full endoscopic. We can do small incisions, but most of the time, how I said, we do microscopic assisted endoscopic approach. So we do the standard incisions for CP angle surgeries that we can do also for schwannomas, for meningiomas. It's the same incision. Everybody has his preferred kind of incisions. I prefer a small curved incision. There's no difference between them. A little bit like this is my kind of preferred incision. So another important thing is to know the anatomy. Of course, that we do a lot of we lead with the school-based anatomy, but when we are dealing with the endoscope, we had a beautiful anatomy, and we have a more, how can I say, a more closer anatomy. So this is one of our works that we did with Professor Fröhlich to explore the anatomy of the CP angle, visualize it through the endoscope. So the indications, when we go through the literature, we have a lot of indications. We can use almost for all of the disease of the CP angle, of the cerebellopontine angle. So far, my indications are for using to assisted vestibular schwannomas, especially for closing air cells at the end of the surgery, or for those cases that have to contraindicate the drilling of the EAC. For cystic tumors also, epidermoid tumors, for MVD, sometimes we can use it. For lesions that is extending through the Meckel's cave, to the Meckel's cave, or those lesions that are invading the petrous bone, and sometimes for meningioma, especially for looking at small pieces of tumors that may be hiding at the end of the surgery. Here I'm going to present just some cases. I hope you can see well the videos. This is when we took off a vestibular schwannoma, and at the end of the surgery we put the endoscope so that we could see some air cells, and then we search for it. Otherwise, we can have a CSF leak. So we find it with the endoscope. With the microscope, it's almost impossible to see it, and then we close it. With the microscope, because of the angle of the visualization, you don't see this kind of cells. For MVD decompression, so for microvascular decompression, This is one case that we did for adonico-basilar. The patient has trigeminal pain. So this is one of the first cases that we did just fully endoscopic decompression. So we can see here the trigeminal nerve. This is the basilar artery that it was compressing the nerve. It's the same technique that we do. Someone is holding the endoscope and the other surgeon is doing microsurgery. So we could put something to split the nerve from the artery. For jugular foramen schwannoma also, if you see here, this has a huge invasion inside the petrous bone. So at the end of the surgery, we could not see very well the petrous bone. So we use the endoscope to, here you can see this is the nerve, this is the fifth nerve, this is the facial nerve, and this is all the tumor inside the petrous bone. So with the endoscope and doing almost like we can mix a little bit of hypophysis surgeries and microsurgery, and we can take off the remaining tumor. I'm gonna pass because it's a long video. For vestibular schwannoma, this is a nice case because when we see here, we think it's a normal one. But when we look at the CT, we can see that we had a high jugular bulb. So we were a little afraid to open the EAC on the beginning of the surgery. Here we can also see that the jugular bulb was high. So we could have some problem with bleeding if we decide to drill the EAC at the beginning of the surgery. So our decision was to finish the surgery, to take out all the cisternal portion of the tumor, and then we add the endoscope. And this is the residual tumor that we saw. Here we can see the cisternal portion. We use the monitorization to localize the nerve, and then also doing the same technique that we do for microsurgery, we did with the endoscope, but adding some techniques that we do in the endonasal surgery. So like this, we could took off all of the tumor. You can see that here the band of the nerves is here, and very gently we can do some traction and contraction, and we can take off this tumor that was inside of the internal acoustic channel. This is the final MRI. This is the patient at the end of the surgery. You can see here that we could take off all of the tumor. See that portion that was inside the EAC is not there anymore. The patient has recovered very well. This is I think is the last case. This is an epidermoid tumor. In my opinion, it's one of the best options to use the endoscope inside the CT angle. So this is an epidermoid cyst, and if you look well, just 1 minute, I'm going to go back a little bit. It has an important extension to the mesial temporal lobe. So this could lead us to thinking in an expanded approach, like maybe petrosectomy or even a large approach. But how this was a soft tumor, we decided to approach it only through the heterosigmoid approach. And after using the microscope, we put the endoscope and we could see these small pieces of tumors. First inside of the acoustic channel. Here we're looking up and we're going to start to cut the tent. So this is the fifth nerve, this nerve that we can see here, and we are cutting the tent. when the tentorium. And when we cut the tentorium, we could see a large wound that the tumor has already done. So this portion is all the portion inside the medial temporal lobe, the medial temporal lobe. And once again, doing techniques that we do on the endonasal approach, we can do here on the CP angle surgery. Here is the medial temporal lobe. And a small piece of tumor inside the Meckel's cave. Also, we could be able to resect. This is the here. I'm sorry. This is the final. Let me put here. Here. Yeah. So this is the final MRI. You can see that on diffusion here, we have no more tumor. And this is the last case, just for meningiomas. I don't think it's a good idea to use the endoscope to resect meningiomas because they are very bleeding lesions, and sometimes they are attached to the nerves. But this was a petroclival meningioma that we did a combined Petroso approach, and we did a tentorial peeling. This is a technique that we are trying to use in all of our Petroso approaches. This tentorial peeling. So by the end of the surgery, we could resect the tumor. This is the tentorial peeling that we can preserve the dura mater of the tentorium covering the temporal lobe. So like this, we can preserve the temporal lobe. This is the final of the surgery. Here are the nerves. And then we could put the endoscope just to a final view, a final look. This is the fifth nerve entering the Meckel's cave. This is the 7-8 bundle. Another view from the acoustic channel, internal acoustic channel, all free from disease. Another view. And this was the final MRI of the patient. So why we have to add the endoscope to microscope microsurgery on the CPA? My opinion is just to go further, we can reduce the extension of open approach, and we can maximize the resections. The endoscope, I always think that nowadays, especially for those that want to be a school-based surgeon, you have to master the microscope and the endoscope, and in a few years, also the exoscope. The main limitations, I think, is the learning curve. I think is a steep learning curve. For those that has already some familiarity with the endoscope that used for endonasal approach, I think that would be easier, but it's not the same surgery that we do with the microscope, especially on the first cases. So we have to deal with the instruments. Also, the instruments might be a limitation because we have the instruments that we use were not developed to those kind of surgeries. So we use the same instruments that we use for microsurgery or for endonasal surgery. So we have to think about, if you want to improve our surgery with the endoscope on the CP angle, we have to improve our instruments, and probably the future will be the use of and the addition of the add of the exoscope and the robotic surgery.
Okay.
Here are all our mentors: Professor Atul, Professor Fröhlich, Dr. Bruno, and Marcos. I'm always grateful for all the learning curve that they provided me. Thank you very much.
Okay, thank you. Please, Professor Goel.
Marcos, are we ready?
Yes, feel free. Thank you, Daniel. Thank you.
Okay, Daniel. So I'm very happy and very honored to be invited by you, Dr. Marcos, and to present in front of your very elegant and eminent neurosurgeons of Brazil, and in front of my dear friend John, who has organized the entire show. So thank you, John. So what, Marcos, I have decided today is to present a summary of my work on skull-based tumor, just a summary to summarize all the tumors and various issues in skull-based surgery. You can see my slide, Marcos?
Yes, it's okay.
Okay, so the basic message that I wish to give is, you see, brain tumors are very important part and parcel of our neurosurgical life. We have to learn how to remove the brain tumors. We have to learn to remove them radically. More than radical, we have to learn how to remove them philosophically, how to get the planes of dissection, and how to avoid complications. So as I go more and more into this business of neurosurgery and in this business of brain tumors, I like to be more and more conservative, more and more try to avoid very extensive dissection around the cranial nerves. If I need to dissect the sixth nerve for a long time, I will like to avoid that dissection. If I have to dissect around the perforators of the middle cerebral artery or basilar artery for a long time, I will like to avoid that dissection. So most important is that we have to learn to dissect, we have to learn to respect the membranes and all, and to know that brain tumors are confined. So today what I'm going to work on is the tumors on the skull base and in the region of cavernous sinus. Essentially, I'm going to summarize my work of last 35, 40 years on this subject. Needless to say that we have to learn the anatomy of the skull base beautifully. We know that anatomy is the key, and we have several fantastic anatomical dissection from Brazil. We know now that we know the president of Rotom Society is in Brazil, Evandro Oliveira from Brazil. Such beautiful anatomical work has been done from Brazil. So I don't have to say much on the importance of anatomy. So this book of mine was published in 1996. And if you realize the cover page of this book is quite an extensive dissection and petrosectomy. The entire petrous bone has been drilled, the carotid artery has been mobilized anteriorly, gastric ganglion has been mobilized superiorly, the facial nerve has been mobilized posteriorly. So this was the cover page in 1996. I must say that I was doing such dissection quite frequently during that period, but now I do not do such extensive petrosectomy and extensive mobilization of cranial nerves and blood vessels. Many of you must have seen these slides of mine, which are my favorite slides. And I have worked on cavernous sinus. I have tried to understand what is the function of cavernous sinus, why the eye of a lion is located in front, and why the eye of a deer is located on the side of his head. Because when the deer runs, the deer looks in front and analyzes the next obstruction and also looks behind. So when the deer is running and the tiger is running behind, the eyeball of the deer runs in front and behind simultaneously, like a front and behind. So very rapid movements of the eyeball. On the other hand, the lion has to look only in front, and the eyeballs, he does not have to worry for if there is something coming from behind or not. he has to look in front and attack this deer. But the deer has to look both front and behind. So the eyeball movements are much brisk and much more quicker. And that is why we had said that the cavernous sinus is bigger in a deer because it caters to eye movements. Bigger the eye movements, in a lion, the eye movements are only 35 degrees. In a human being, they are 120 degrees. In a deer, they are 180 degrees. So the eyeball movements, more the eye movements, bigger the cavernous sinus. So we said that the range of movements are very important in determining the size of cavernous sinus. And cavernous sinus has a big role in eye movements. We also said that the cavernous sinus has a big role in vision. So some of these articles I'm showing, I'm not going to go in detail on all these things, but I wish that you can read some of these very beautiful articles that I had written some 35 years ago. We had also said during that time that the entire venous drainage of the eyeball is in the cavernous sinus. So if you press your eyeball, the quick drain off that cavernous sinus presence to the venous structures is very important to this eyeball, which is the extreme degree of complex hydrodynamics. The pressure in the lens, pressure in the anterior chamber, pressure in the posterior chamber is very important for the function of the eyeball. And the retina, which does not have, the retinal artery, which does not have any muscular layer, if you press the eye like this, the retinal artery can rupture if there is no cavernous sinus drain off. So there are various things that we had written during that time about what the function of cavernous sinus is. So we had said that the cavernous sinus is like circle of Willis. We had labeled it as circle of relief. So if you press the eyeball like that, the venous drainage goes to the cavernous sinus. It relates to the opposite cavernous sinus and the opposite eyeball. So when you press, there is some degree of diplopia for some time, and then it neutralizes. So this cavernous sinus function is important. Cavernous sinus is not just a vestigial organ. It has functional relevance and functional importance. When there is cavernous sinus thrombosis, the eye movements are stopped, not because the cranial nerves are affected, not because the sixth nerve is gone, not because the third nerve is gone. We speculated because the venous drainage is gone. So venous drainage we related to the function of eyeball, to the function of vision, and in various other functions. So cavernous sinus, we said that it has big role in eye movements, and also it has a big role in vision. And the location of the eye lateral to the head. And this slide of mine is 32 years old. 1992, I had given this slide for the first time. Cavernous sinus of a fish is much bigger in proportion to cavernous sinus of a human being and cavernous sinus of lion. Imagine if you puncture the eye of a fish, the fish may not be able to swim because eye is not only in vision and eye movements, but also in balance. So if you puncture the eye of a fish, the balance goes and the fish may not be able to swim properly. So the beauty of a person lies in the eyes, that is one thing, but also what is behind, and that is cavernous sinus. So this is what is a speculation, but this has meaning. It has a philosophy. It suggests that everything in the body has some function. So cavernous sinus has a big function. So location of pituitary gland, which is not only not in the skull, it is not intracranial, it is not extracranial. It is located by the side of cavernous sinus, by the side of nasopharynx, and has, this nasopharynx gives the external temperature to the pituitary gland, to the cavernous sinus. Carotid artery gives the temperature of the body, and both of them relate to the pituitary gland, and then it relates to the rest of the body. So we said that cavernous sinus has a role in temperature regulation, in regulation of the pituitary function, and various other things we mentioned. And I want, my dear friends, please read these articles, and I know that they are fantastic and you will enjoy reading it. So membranes are the mother of brain. This sentence I have taken from Arabic word, alum al-dimag. Membranes are the mother of brain. Dura is durable. Dura covers the brain. There is no hole in the dura. As the cranial nerves go out or blood vessels go in, there is a dural layer which goes along the artery and along the nerve. And there is a completely impermeable wall that dura forms around the entire brain. So surgery of cavernous sinus 30 years ago or 35 years ago was not very popular and not very frequently done because of the difficulties and because of the imaging also was not good during that time. Before the era of MRI, we didn't know where the carotid artery is, where the dura is and things like that. So this article of mine about 30 years ago, I think was quite an article on the subject. So MRI, when it was introduced, it gave an idea as to where the carotid artery is, whether it is compressed, whether it is displaced, or whether it is encased. And so this article, on the basis of how the artery is displaced and how the artery is encased and how the artery is squeezed by the tumor, you can identify the nature of the tumor, you can identify the histological nature of the tumor, and then plan your operation. So most important thing for me during my career is that I have been involved in doing very complex and very heavyweight neurosurgery for a long time. This was my case in 1993, which I operated. You can imagine the posterior communicating artery is encased, basilar artery is encased, both carotid arteries are encased, and this tumor I did in 1993, 31 years ago. So the beauty is in skull-based surgery, in complex neurosurgery, more you operate, daily you operate, you love the smell of the operation, love the feel of the tumor, learn the art of breaking the tumor, learn the art of dissecting in the arachnoid spaces, learn the art of demolishing the tumor, learn the art of removing the tumor without major coagulation. If you go on coagulating, you might lose the plane, you might lose the artery, you might lose everything. What my style is that learn the art of breaking the tumor, learn the strengths of the tumor, learn the weaknesses of the tumor, and then exploit those weaknesses. This was another tumor in 1995. I did quite a tumor, cavernous sinus, orbit, and things like that. Another tumor in 1995, there was a small residue. Now, whether this residue has to be treated by radiation or not, I have never done radiation after leaving a residue, and I still think that giving radiation is not necessary. As long, and this patient is still alive after 1995. The question is, my answer to this question is, as long as you can remove the tumor, as long as your knife can work on the tumor, as long as you think that you can safely remove the tumor, you must give the option of surgery. And when you think that your option of surgery is not, safe, then only one might consider radiation treatment. So this was another tumor I operated in 1997. I did a very beautiful resection in this tumor, but the patient developed hemiplegia at that time in 1997. This patient is still alive, but severely hemiplegic. And I'm wondering whether my radical resection was good, whether I should have done conservative resection and things like that. This is another tumor behind the orbit and in the cavernous sinus. And first I removed the orbital tumor and then I removed the cavernous sinus tumor. This was an hemangiopericytoma. This was a schwannoma. And both tumors radical removed, and this patient is alive for a very long time. So this was the first article in the literature which said that intracavernous sinus tumors, I'm not saying aneurysms, like Vinko Dolenz had said about aneurysms. And Vinko Dolenz had said about trigeminal schwannoma. And I said this article, intracavernous sinus tumors, you can do. We had suggested extradural approach for these tumors in 1997. This tumor, I'm not sure how many of you can recognize this tumor, but this tumor is the most benign tumor of the body. It is the most vascular tumor, and it is cavernous hemangioma of cavernous sinus. And it has got very characteristic extension. It respects the dura. It remains within the cavernous sinus. It goes towards the intercavernous sinus connection. It goes towards the orbit, goes towards the metal cave. Lateral wall is always intact, and it is intracavernous. If you do not understand this tumor and come by nose through endoscope or whatever, you can have a very huge bleeding in this tumor. So these tumors are intracavernous, they are intradural, they remain within the dura. They encase the carotid artery, and they displace the sixth nerve, they displace the fifth nerve by the side, they displace the third nerve on the dome, and you have, this was the first tumor, first case in the literature which showed complete resection of this tumor in 1991. Even when these tumors become big and huge, they remain within the dura. They remain within the dural confines. They go towards the intercavernous sinus, they go towards the orbit, they go towards the metal cave. Lateral dural wall is intact. All the cranial nerves are displaced on the dome of the tumor. Sixth nerve is displaced on the undersurface of the tumor. So they are confined tumors. They do not look vascular on angiography. They are angiographically occult, but they are heavily vascular tumors. So we reported this in 2000, 24 years ago, extradural approach to these tumors. Come from extradural, they are slow-growing tumors. The brain is not tight. Open the dura, work within the tumor, get the vascular supply which comes from the arteries of the internal carotid artery and from the capsular artery. And once you have taken the artery, the whole thing becomes much easier and quicker, and you can have identified the sixth nerve early in the picture. So extradural approach we had described, and this was another tumor. I will not have too much time to show the videos and all, but let me show you some. This video is 24 years old video where it is an extradural approach. I think I will avoid showing videos. This is a third nerve weakness, and this third nerve recovered following surgery. This is another case where an extradural approach was adopted. You see, extradural, work within the tumor, first you come around the tumor, expose the tumor outside, it will bleed furiously. Do not start breaking the tumor. You see, come from outside. And don't have to worry, if you are going to have a hemostasis and you want to work, you want to have a clean field, then you are not going to be able to remove this tumor. Identify the sixth nerve, save the sixth nerve, protect the sixth nerve, work around the tumor, and then break the tumor. And then get to the artery, inferior lateral trunk of the carotid artery, get to the artery, coagulate that artery, and you will find that this bleeding will very rapidly stop, and then you will be able to remove this tumor. You see here, you see this is the artery which is feeding the tumor. You coagulate this artery, there will be complete hemostasis. And you can imagine once you get the hemostasis, then the whole story changes. Basically what I'm saying is these tumors are confined. These are heavily vascular, And once you get the major feeder, you don't have to keep on coagulating. Believe me, this tumor was removed in 20 minutes. I have whatever editing has been done is being done here on my screen. But you see how the tumor can be removed. These are vascular tumors. These are dangerous tumors. But if you remove, you can give new life to these patients. And they are benign tumors. Even when they become big and huge, they remain within the dura. They encase the carotid artery. Here there was a aneurysm like AVM, feeding artery aneurysm. So the aneurysm was clipped and the tumor was removed. This was another tumor, huge tumor with the same concept. Come extradural, walk around the tumor as much as you can. Rapidly go into the tumor. Don't just go on coagulating and all. Most important is don't make a mistake of coming from the nose, which will be a very dramatically dangerous mistake. This was hemangioma. Now I want to talk about pituitary tumors. And pituitary tumor is my main, very predominant subject. We have done more than 5,000 pituitary tumors in my career. And I want to quickly show how pituitary tumors respect the dura. They become big and huge. They become sometimes very big and huge and dangerous looking, but they respect the dura. Now, what my contribution in this subject is, when these tumors become big, the diaphragm celli dura goes along the tumor. It goes above the tumor. So diaphragm is above the tumor. This concept was not there 25 years ago. And most of these tumors were removed transcranial. All these tumors were transcranial surgery during that time. But what we said is that the dura of the diaphragm goes up, the dura of the celli remains here, and the whole tumor is interdural in location. Earlier concept was that there is a hole in diaphragm and the tumor, this part of the tumor is subarachnoid in location. So we said that the diaphragm goes up and even these nubbins, there is a diaphragm here. Even in this nubbin, there is diaphragm here. I have no hesitation to say that if you do not have this concept that the diaphragm is here, dura is here, you cannot remove such large tumor. So this tumor, if you want to remove, you don't have to go transcranial. You have to know one thing, that the diaphragm is here, the diaphragm is here, and these tumors can be removed radically and safely and quickly. Pituitary tumor is a different tumor. It is not like hemangioma. It is not that vascular. It is vascular, but it is soft. It is breakable. Learn the art of understanding the tumor. So when the tumor encases the carotid artery, it is cavernous sinus involvement. So lateral wall of the cavernous sinus is intact, diaphragm is intact. So when it involves both cavernous sinus, lateral wall is intact, diaphragm is intact. It remains within the dura. It remains, diaphragm is intact, lateral wall is intact. The diaphragm may be tight, lateral wall may be tight, but not transgressed. So dura protects. The tumor respects the mother dura. Now carefully look at this slide. The tumor is inside the cavernous sinus. This is intracavernous. This slide, this concept was never there earlier. Diaphragm is elevated. This is the dural roof of the cavernous sinus elevated. So this tumor is inside the cavernous sinus. This is dura of the roof of cavernous sinus. This is diaphragm celli dura. This is dura of the roof of cavernous sinus. Dura of the roof of cavernous sinus. This tumor still remains within the dura. This is diaphragm dura. This is dural roof of cavernous sinus. Believe me, this concept, if you have to operate this tumor, if you do not have this concept, you cannot operate this tumor. Dura of the roof, dura of the diaphragm, dura of the roof. Grade 4 tumor is when the tumor transgresses the dura of the roof, dura of the diaphragm, and encircles the arteries of the circle of Willis. So this is my classification. Grade 1 is when it does not involve the cavernous sinus. Grade 2 is when it involves the cavernous sinus. Grade 3 is when it elevates the roof of cavernous sinus. Grade 4 is when it encases the arteries of circle of Willis. So this is my grading. And I have no hesitation to say that this dural anatomy, which was not understood 25 years ago, has completely revolutionized pituitary surgery. Whether you use endoscope, whether you use microscope, that is a very minor part of the whole operation. Pituitary tumors are soft tumors. Pituitary tumors are breakable tumors. Just remove the anterior wall of the cella. No need to remove the tuberculum celli or prenum sphenoidal. Break into the tumor, and you can very rapidly remove this tumor in 10 or 15 minutes. So diaphragm is like uterus. It is the strongest muscle of the body. It pushes the baby down. Similarly, this pregnant tumor, the baby is pushed down by the diaphragm. It pushes, it has the power to push the tumor down. Break the tumor. And these kind of tumors, if you are removing in 2 hours or 5 hours, you don't know pituitary tumor surgery. This tumor should be removed in not more than 25 minutes. Break the tumor, the diaphragm will come into picture, and you will have a beautiful post-operative image and beautiful post-operative patient. This subfrontal extension, the whole world was doing transcranial operation, but dura is present. It is such an important issue. This kind of tumor, the dura is there. Remove the anterior wall, break the tumor, learn the art of breaking the tumor, learn the art of delivering the tumor. This tumor I operated in 2001, 23 years ago. You can imagine the understanding at that time that this diaphragm will remain intact. So I removed just the anterior wall and removed the tumor 23 years ago by understanding the concept that the dura is here and the dura will push the tumor. Similarly, this tumor I operated in 1999 by just operating on the anterior wall and removing the tumor, and the diaphragm ultimately comes into the picture. Removal of tumor of the cavernous sinus is a different ballgame, but understanding the concept that these are soft tumors, these can be sucked, these are not firm tumors like meningioma, and in functional, when to remove, when not to remove, there are very critical issues in pituitary tumor surgery. This tumor, which is elevating the roof of cavernous sinus, if you have this understanding that the dura is intact, the third nerve is not inside the tumor. Third nerve is here in one of these corners. Break the tumor, remain within the dura, and you can remove this tumor. So this tumor I removed in 2002 by breaking the tumor. This is under the roof of cavernous sinus. This is under the roof of cavernous sinus. So you can imagine such a beautiful anatomical concept. And when the tumor transgresses the dura of the diaphragm, it is a different world. The tumor surgery becomes different. The concepts are different, whether these tumors have to be removed radically or whether they can be removed partially. This is a different story. Trigeminal neurinoma. This article of mine, which was published in 2003, several beautiful things were discussed in this article. First and foremost, we described that these tumors arise in the region of Meckel's skin. Second thing we described is that these tumors remain within the dura. This part of the tumor is within the dura or interdural in location. In 2003, I described that this part of the tumor is like acoustic tumor, and this is subarachnoid in location. But later in the field, as we grew, our experience grew more, we said that many of these tumors can be interdural in location. So understanding the fact that these tumors are within the confines, they are confined tumors. You break the tumor, remain within the dura. And in this article, for the first time in the literature, we described that you can improve the function of the fifth cranial nerve by saving the fibers of the fifth nerve. When you are doing trigeminal neurinoma surgery, the most critical nerve is V1 division. V1 you have to save, because if you do not save the V1 division, you can have a very serious damage at end. So this was my article. In 1995, we discussed that trigeminal neurinomas can be removed by an interdural approach, like here, without any craniotomy. Open the Meckel's cave, work within the dura, remove the zygomatic arch like this. The temporalis muscle is atrophied in this situation, and you can have a good exposure. So this was my approach. I don't do this approach now, but you can imagine the understanding. These tumors were not very frequently even done at that time in 1995, but we removed this tumor without any craniotomy. This was another tumor going posterior fossa and in the Meckel's cave. And we removed it by just this craniotomy, by widening the Meckel's cave. And this was in 1994, 30 years ago, without doing any craniotomy. So, and this was another during the same period of time by just opening the dura of the Meckel's cave. Interdural, respect the dura. Work within the dura. Learn the art of breaking the tumor without too much coagulation. If you go on coagulating these tumors, you can never remove this tumor one, and you will probably damage all the cranial nerves in the vicinity. So these tumors remain within the dura, interdural. Even some of these, majority of these posterior fossa tumors are subarachnoid, but many a time these tumors can be within the dura, particularly multi-compartmental tumor. So in 1991, we used to remove, and the whole world used to remove these tumors in 2 stages. So this tumor was removed by me in 1991 in 2 stages. First, we removed this part of the tumor, and then we removed this part of the tumor. So this was in 1991. In 1992, this was another tumor where I removed this part of the tumor first and this part of the tumor second. So 2-stage surgery was the norm. But then, of course, understanding of the dura, understanding of the things came in picture, and then 1-stage surgery has always been my norm for trigeminal neuroma. And initially in 1996, we used to do very extensive exposure. And this was the first article in the literature where subtemporal craniotomy was included and mastodectomy was added to the exposure. I used to do basal cut by removing the root of the zygoma, roof of the condyle, roof of the external ear canal during that time for basal pictoclaval meningiomas and for trigeminal neuroma. But now I do not do this kind of extensive exposure. I just split the temporalis muscle and do this basal work. Temporalis muscle is sometimes rotated anteriorly. This is my not a very major exposure. And we have done more than 320 trigeminal neurinomas in my own experience, which is the largest experience in the world on trigeminal neurinomas. And my exposure has been limited. My radicality has increased in trigeminal neuronoma. And the safety of cranial nerve, safety of trigeminal nerve is the most important. Break the tumor without taking the trigeminal nerve. Come from lateral, open the dura, work within the tumor. These are not vascular tumors. These are not very firm tumors. Break the tumor, and then how to go in the posterior fossa, how to cut the tentorium, how to sacrifice or not sacrifice the superior petrosal sinus, how to go in the posterior fossa. We know all these things, and we have to learn all these things by our skull-base approaches. Here there is a small nubbin of tumor. This is also within the dura. This also remains within the dura, and this we have to know that this is not in relationship to the carotid artery. Carotid artery is displaced medially. This tumor remains within the confines of the dura, and that is very important. This tumor has taken the petrous apex. It has eroded the anterior coronoid. So there is no need to do any petrosectomy. So if somebody says, I want to do petrosectomy for trigeminal neuronoma, it is not correct because the tumor itself erodes the petrous bone. When the tumor goes extracranial, like along the V1 division, along the V2 division, along the V3 division, we said that this part of the tumor is also interdural in location. This carotid artery is displaced medially by the tumor. So you can imagine if the carotid artery is displaced medially by the tumor, we have to use, as we described, transcranial interdural approach for these tumors. These tumors can be done nasal, can be done through maxillary route, but that you have to decide. Even when the tumor has a recurrence, like when there is a recurrence of tumor, trigeminal neurinoma, in an apoplectic or sudden recurrence, they remain within the dura. This is third nerve neurinoma. Third nerve neurinoma, this is not a, it has a defined pattern of extension. It remains within the mother dura. It does not transgress the dura. If you have this understanding that trigeminal neurinoma arises within the oculomotor system and then remains within the dura, it arises within the oculomotor system, and when it, like Meckel's cave, arises from the Meckel cave and grows. Oculomotor system and grows and takes the dura. So there is a dural cover around it. So the tumor around it, the wall is not capsule of the tumor, it is duras. Open the dura, small opening, and then work within the tumor, and you can save the third nerve. There is not a single article in the literature mentioning that you can improve the function of the third nerve in these cases. So there is dura around the third nerve, oculomotor nerve neurinoma. This is very, very important. Sixth nerve neurinomas is a different cup of tea. Sixth nerve is within the cavernous sinus. We are still working on how the dura is displaced along the sixth nerve. I'm still not exactly sure, but sixth nerve neurinomas are quite rare tumors. Seventh nerve tumors. You see, this is the seventh nerve neurinoma. It arises from the geniculate ganglion. Like trigeminal arises from the Meckel's cave, from the Gasserin ganglion. Seventh nerve tumor arises from the geniculate ganglion, and it goes in the middle fossa and in the posterior fossa along the nerve. It remains within the dura. So interdural approach for seventh nerve is a very beautiful approach. It is a quick approach. You make a small incision, open the dura, and work within the tumor. Do not remove the capsule, because that is not a tumor, that is dura. And some part is cystic, some part is necrotic. Work within the dura, and in the traverse of the seventh nerve, save the seventh nerve function. Another beautiful tumor we described was lower cranial nerve schwannomas. They arise within the dural confines. They are interdural in location. I have no hesitation to say that this is an absolutely mandatory understanding. So this tumor is, the dura is around the tumor. And you do mastoidectomy, you come and open the dura and work within the tumor, go outside the skull, inside the skull, but retain the dura, and you can save the function of the lower cranial nerve. For the first time in the literature, in this article, we mentioned that you can improve the function of the lower cranial nerves by working within the dura. So this tumor is large, this tumor is dangerous, but this tumor is confined to the dura. And this understanding is absolutely important if you are going to remove this tumor safely, because all the lower cranial nerves are displaced around the tumor. Only a small one fiber of the lower cranial nerves makes the tumor, and the whole tumor is within the dural confines. Second nerve tumors, C2 neurinomas. C2 neurinomas are quite common, C2 neurinomas. So about 15 years ago, 20 years ago, we said that the C2 neurinomas, there are three compartments like trigeminal neurinomas. This is intradural and this is interdural, trigeminal neurinoma. Similarly, we said the C2 neurinoma, this is intradural and this is interdural. This is what we said earlier. This was my article in 2008 where we said that this part of the tumor is subarachnoid in location. But in 2018, we changed that. We said that even this part of the tumor is interdural in location, interdural. So make an incision in the dura here and work within the tumor, work within the dura and preserve the dura. You don't have to do any kind of laminectomy. So this is the first time in the literature we remove this tumor without any bone work, without any laminectomy. Just open the dura. C2 ganglion is located behind the C1, C2 articulation. It is extra spinal in location. So we said that C2 neurinomas should be and can be removed without any bone work. Like we said for trigeminal neurinoma, we can remove trigeminal neurinoma without any bone work. So no craniotomy for trigeminal neurinoma first time. And no laminectomy for C2 neurinoma we described for the first time. So C2 neurinomas are very similar to trigeminal neurinomas. They remain within the dura. They remain within the dura like trigeminal neurinomas. Chordomas are different. Chordomas arise from the bone and they displace the soft tissue. They are extradural in location. They displace the carotid artery anteriorly. They displace the Gasserian ganglion and cavernous sinus superiorly. So carotid artery is displaced anteriorly. The dura is displaced posteriorly. So the whole tumor is extradural. It respects the dura. You see this article, one of my most beautiful articles I wrote in 1995, that chordoma and chondrosarcomas displace the carotid artery anteriorly. The carotid is here. So there is no artery here. There is no artery here. So you can come from the lateral perspective and you can do middle fossa subgasserian ganglion approach for these tumors. This is what we described in 1995. Come from lateral, extradural, and work within the tumor, avoid the dura, avoid the cranial nerves, and you can have a beautiful tumor resection. So carotid artery is displaced anteriorly in chordoma, carotid artery is displaced medially in trigeminal schwannoma, and this is quite a diagnostic kind of feature. Trigeminal chordomas are soft tumors, chordomas are jelly-like tumors. They can be removed quickly and radically. How much bone has to be removed is a different issue. So trigeminal, chordomas, lateral approach is also good. I can understand for chordomas, the whole world will do endoscopic resection, and we also do endoscopic or transnasal resection on many occasions, but lateral perspective approach is also a good option in these cases. You see, this is a lateral perspective, how the carotid artery is under your control, how you can identify and displace the various nerves and various blood vessels, and you can do a very radical resection. So I know endoscopic approach is good approach, but lateral approaches has its own indication. I will show you supracerebellar approach for clival chordomas. So this is a clival chordoma. You can come from the nose, you can come from lateral, but we went from supracerebellar. Most important issue is if you come from the nose, the sixth nerve is here. Sixth nerve is displaced posteriorly. The carotid artery is displaced anteriorly. The sixth nerve is displaced posteriorly. So sixth nerve saving and preserving is very difficult from endoscope. On the other hand, you come from lateral, identify the sixth nerve early in the operation, and then debulk the tumor. So supracerebellar approach is a good option. I'm not saying the best option, but in some cases, it can be a worthwhile option. So this is another case of supracerebellar approach. This is another case. You can come from the nose, you can come from lateral, but we did this by a supracerebellar approach, which is also beautiful. The other thing is you can come down, you can come up, and you can identify the various nerves, and then from this direction, you can go use endoscope if necessary. If you come from nose, it is a little bit, you have to do a little bit more work from here. But of course, nasal approach is also not a bad option for chordomas. This is nasopharyngeal angiofibromas. It is not only extracranial, but they are extradural, and you can do a very blunt dissection for nasopharyngeal angiofibromas. We have described transcranial approach for this, but I don't think I do transcranial. I do a nasal midfacial degloving approach for these tumors because you can very easily define a well-defined border for these tumors. So this was my approach I described 30 years ago, but I don't do this approach, this transcranial approach. There are several other tumors like epidermoid tumors, dermoid tumors, angiofibromas, aspergillomas, various other fungal infections in the cavernous sinus, tuberculomas in the cavernous sinus, meningiomas in the cavernous sinus. But what I'll do is, Marcos, I will like to stop. I will like to discuss meningiomas in my next lecture if you will, because if I start discussing meningioma, it will become a very long lecture. I will like to talk on meningiomas in my next session, Marcos.
Okay, Professor. Luis, can you comment something, please? Luis? Danielle? Professor, and what do you think about those techniques of embolizations of the tumor endovascular? Is it necessary or unnecessary?
This embolization I used to do for nasopharyngeal angiofibromas. I used to do embolization, but I completely do not do embolization because it is dangerous, and I have lost vision in one of my patients. After that, I have not done embolization for nasopharyngeal angiofibromas. For glomus tumors, which I will like to discuss in my next lecture on glomus tumors with you, Marcos. Glomus tumor is one tumor where embolization is helpful, and embolization we still recommend. But other than glomus tumors, I do not do embolization for any other brain tumor. Now, Daniel, Daniel?
Anyone from the audience want to talk? Luis, assume aí. Anyone from the audience want to make any comments? Danielle, are you there? No.
There is Muhammad on the screen. Muhammad in the audience. Muhammad?
Yes, sir.
My dear Muhammad.
Okay, there you are.
Yeah,
Yes,
yeah, I'm
Muhammad,
here.
any question for me?
Yeah, I would like to ask you about the chordoma, especially
Yes.
in the clivus, the midline chordoma, those that comes from the anterior and goes posterior. How do you handle it? How much radical should be done in this kind of cases? Sometimes they go under the sphenoid sinus.
See, I will say that chordoma is one situation where chordomas are extradural tumors, and chordomas are extradural approach is a good option. So endoscopic transnasal approach is a good option for chordomas, and when they go in various directions, endoscopic option is a good option. And you must learn endoscope to remove chordomas which are, going here and there in various corners.
John, can you give audio to Luis and Fabio?
Okay.
Dr. Yangdong is also on the screen.
Okay, Lewis, it looks like he's already in there.
I think mine is okay. My name here is Marcos Wagner for any reason, but Fabio, Professor Fabio, you can start, please, your comments.
I'd like to thank you for a wonderful presentation. I think the combination of a microscope and endoscope for CP, something like neurinomas or meningiomas, is a great advantage for thorough resection and preservation of the challenges, the facial nerve. Thank you for your wonderful presentation.
Thank you. Thank you so much. You see, endoscope is important, microscope is important, but most important is the understanding of the tumor is important. You have to understand the tumor. You have to understand the firmness of the tumor, the vascularity of the tumor, the location of the tumor, the dural confinement of the tumor. If we have the understanding, then whether you use endoscope is one thing, whether you use microscope is another thing, but how to attack the tumor on the basis of anatomical confinement of these tumors is very important.
Luis?
Okay. First of all, on behalf of the Northeastern Society of Neurosurgery, I would like to thank to the panelists, Dr. Evans, who is now in São Paulo, in Campinas, but he's from Northeast. He was born in Alagoas. Dr. Daniel, a school-based neurosurgeon who is gaining ground every day with his beautiful work. Dr. Fabio, with his great experience, who collaborated with us on more than one occasion in our webcasts. A big thank to Marcos Wagner, the creator of this event, who is always on move, organizing events, inviting people, bringing ideas, such this idea of the Chiari mission. It's very interesting, Marco. I was thinking in some names like Chiari Scope, Chiari Quest. We are going to move on this, and Professor Goel is officially invited by our society to collaborate with us on this. And I especially thank to John and Professor Goel for your willingness, Professor, to be here with us in these events. Ever since a student of medicine in Congress, I've followed your firm stance and concepts in your catchphrases like red is my favorite color, dura from the cavernous sinus, diaphragma cella, dura from the cavernous sinus for dozens and dozens of exams in succession. And I would like to thank you, congratulate you for your strong concept based on great deal of experience and results that you show on the display for anyone who wants to see. So who doesn't want to believe, just see. And with regard of pituitary tumors, with respect the limits of the diaphragma and the dura of the cavernous sinus, how does the involvement of anterior cerebral artery occur? In your view, are the artery always embrace the tumor, protected by capsule, and never literally in contact with the parenchyma?
No, you know what? When the tumor grows up, the diaphragm goes up. Very few occasions, it is very rare to have the artery of the circle of Willis encased by the tumor. Those I call grade 4 tumors, grade 4. And many of these grade 4 tumors are hormonally active tumors like prolactinomas and things like that. So when you have a pituitary tumor and when you have MRI showing encasement of the anterior cerebral artery, those are grade 4, those are very dangerous tumors to operate. So you must study that hormonal profile of these patients very, very carefully. And many of these are hormonally sensitive. So I am not yet convinced about grade 4 tumors, whether to remove them radically, whether to remove them partially, whether how much. So grade 4 tumors where the anterior cerebral artery is encased, where the perforators of the internal carotid artery are encased, those are very, very dangerous tumors. Those are grade 4 pituitary tumors.
Do you suggest like transcranial in these grade 4 types, like to jump around these perforators and work easier transcranially?
When they are heavily encased, you cannot remove from the nose because you can damage the perforator and you can have a very big disaster at hand.
Exactly.
And you know, the other thing in these grade 4 tumor is whether you should remove them radically, whether you should do biopsy, because these are dangerous tumors. They encase all the perforators in that area. They don't encase one perforator or two perforators. So these are grade 4 tumors are very dangerous. And, you know, we have had disasters in these tumors. And I'm still working as to what is the best option for these tumors. More recently, I'm working on proteomics of these tumors, proteomics, and also the hormonal sensitivity. So, drug treatment may be a good option in grade 4 tumors. Rather
Now we are
than
looking for your update.
John, audio for Luis.
Oh, anyone more in the audience? Any questions or comments to the sessions? Okay, so again, thank you very much for all the panelists. Thank you, John, and the team from Neurosurgical TV. Thank you, Professor Goel and Marcos. And you'll see soon another event like this, very rich. Thank you, everyone.
Thank you.
Thank
Have
you.
a
Bye-bye.
Sunday.
Bye-bye.
Bye-bye.
Yeah,
Bye-bye.
Dr. Goel is going to Pakistan and now Brazil in one day, in a space of 3 hours. Thank you, Dr. Goel.
Thank
Thank you.
you. Thank
Yeah.
you for organizing this beautiful show and teaching the whole world. You see, you have taken the message of neurosurgery in all the nooks and corners of the world, and no question, this is what your great contribution to the subject of neurosurgery. Thank you, John.